You have an 80-year-old female patient who presented with a mechanical fall that happened 2 weeks ago, presented with reduced consciousness and open eyes to pain, and she also makes incomprehensible sound and withdrew to painful stimuli. What are the main findings on the following CT scan? A right-sided, crescentic in shape, hypodense lesion that's causing significant mass effect, and this mass effect is represented by midline shift, effacement of the sulci, and compression in the ventricles. You can see the ventricle on this side does not look the same as the other one on the other side. And this is the frontal horn of the lateral ventricle, and that's the occipital horn of the lateral ventricle. That's the midline, or this is the septum pellucidum, and as you can see, it's completely shifted from the midline, and the reason why this patient has a right-sided subdural hematoma. What does loss of gray matter suggest in this patient? It does suggest that this patient had a significant head injury at some point, and also that this patient is very likely to have a very long-term cognitive disability or cognitive issue. GCS in this patient, and this is that you would like to go back to the stem and revise the Glasgow Coma score or Glasgow Coma scale. And the patient open eyes to pain, and this is E2, and incomprehensible sounds is V2, and withdraw to painful stimuli, this is M4. The patient GCS will be, all right? And it's almost always an indication. If you have a patient with GCS 8, you need to think of intubation. So if it's 8, intubate, right? Management of subdural hematoma, well, it depends. So this question is a little bit tricky because it doesn't really specify if this is an acute subdural hematoma or chronic subdural hematoma. I do understand in this scenario we're talking about a chronic subdural hematoma, which is absolutely fine. However, we need to consider the other options as well. So I would say if it's an acute subdural hematoma, usually the management is one of two options, whether it's a conservative management or decompression in the form of craniotomy. And if it's a chronic subdural hematoma, the management is usually either conservative management by watching and waiting and repeating scans and stopping the anticoagulation and reversing the anticoagulation as well, and also correction of the clotting disorder that the patient might have. And physiotherapy, cognitive therapy, including with the occupational therapist as well. These are the things that you can do as conservative management. On the other side, the surgical management would include one of two things, whether it's two burr holes, one in the frontal, one in the parietal side, and just washing the hematoma out, or a mini craniotomy or a decompression in the form of a mini craniotomy, which is a small craniotomy. And this in comparison with acute subdural hematoma, acute subdural hematoma is much more serious, with a much more bigger operation that includes removing big part of the bone and decompressing the whole hemisphere. The tracheostomy tube advantage, the tracheostomy tube, as you can see, the flow chart here is management. Is it acute, surgical, and conservative? Is it chronic, conservative, and surgical as well? And you're just following that flow chart, which is, it's actually quite nice to look at it and try. It's a good summary or a quick summary for the management of acute and chronic subdural hematoma. The tracheostomy tube advantage, this includes it's easier in cleaning and less likely the patient will aspirate, and less dead space in basically the respiratory tract, and better tolerated for a long time, and also help weaning from the ventilation. So this scenario doesn't usually come on its own. It will come in relation maybe to an extradural or any type of the other scenarios like ISP management and ISP monitoring, which are definitely covered in other areas of the exam. Thank you.